Hello, friends, and welcome to episode 1212 of the Juicebox Podcast. Tom Blevins is an endocrinologist at Texas Diabetes and Endocrinology in Austin, Texas. Today, Tom is going to come on and share his expertise so that we can better understand GLP medications. I'm talking about Wegovy, I'm talking about Ozempic, Zepbound, Mounjaro, and more. Please remember while you're listening that nothing you hear on the Juicebox Podcast should be considered advice, medical or otherwise. Always consult a physician before making any changes to your healthcare plan or becoming bold with insulin. You can find out more about Dr. Blevins at texasdiabetes.com. If you or a loved one has type 1 diabetes and you'd like to be involved in research, all you need to be is a U.S. resident, and you can head to t1dexchange.org/juicebox. When you complete their survey, you are helping with type 1 diabetes research. You'll also be supporting yourself and this podcast. t1dexchange.org/juicebox. When you place your first order for AG1 with my link, you'll get 5 free travel packs and a free year's supply of vitamin D. drinkag1.com/juicebox. Don't forget to check out the private Facebook group, Juicebox Podcast, Type 1 Diabetes, with over 50,000 members. This episode of the Juicebox Podcast is sponsored by Omnipod 5. Omnipod.com/juicebox. If you have FUMU, the fear of missing out on Omnipod, you don't have to have that any longer. Just go to my link, omnipod.com/juicebox. This episode of the Juicebox Podcast is sponsored by the only implantable sensor rated for long-term wear, up to 6 months, the Eversense CGM. EversenseCGM.com/juicebox.
Hello, everyone. My name is Tom Blevins. I'm an endocrinologist at Texas Diabetes and Endocrinology in Austin, Texas. I work at a clinic where there are about 12 endocrinologists, and we have about 12 to 15 advanced practice providers. And we see a large number of people with diabetes, especially type 1, and we also see a lot of people with type 2 diabetes, of course. We treat people with pumps and technology and even just regular injections. Happy to be here.
Oh, I appreciate that very much. Thank you. How long have you been an endo?
I've been an endocrinologist since about 1986. I finished training and went to Baylor College of Medicine in Houston and got boarded in internal medicine, then endocrinology and metabolism, ultimately got boarded in lipidology as well. So I've been in practice for about that long. I think that adds up to be about 38 years.
What drew you to it initially, and is it the same thing that you do today?
Of course, back in the 80s when I was in training, endocrinology was kind of a different space. A lot of diabetes, a lot of thyroid. I really was fascinated by the conditions, and I saw a big potential to help people. You know, interestingly, I really liked the people I worked with who were endocrinologists, and that attracted me. Now, over time, of course, things have changed a huge amount, which is really fortunate for everyone. And diabetes has evolved from the days of MPH and ultra-lenti and all that, the huge fingerstick devices, which I don't know if you've seen those. You're probably too young to have seen those, but the old iTones and the evolution of technology has been just incredible. And then the evolution of the therapeutic agents as well.
Yeah, and that's why you're here, Tom. So can I call you Tom, or would you prefer to be called Dr. Blevins? Or
Tom is good.
Tom's good. Okay. So you mentioned something else, though. You got boarded in lipocrinology. Is that right?
Lipidology.
Lipidology?
That means,
okay.
Lipids. You know, like lipids. Interestingly, you talk to people about cholesterol and their LDL, the good and the bad and all that. And that sounds very basic, but really there's a huge world underneath that. There's a board, believe it or not. That's the one you study for, and there's a Society of Lipidology, and I'm a fellow of that group. And there was a lot of work done in Houston, and that's where I trained with people like, DeBakey was there, the surgeon, and the cardiovascular surgeon. Then a guy named Tony Gatto came in to be the person that did the lipids to help prevent some of that heart disease that they were treating. Then a few other people, very smart people, came in, and I was fortunate to be able to train alongside them. So lipids, part of endocrinology, really. It's metabolism.
Is there any intersection between that and why you and I are talking today? Your understanding of lipids, endo, and how you came to pay attention to GLPs?
Not exactly. It's another aspect of metabolism, yes, and that is what endocrinology is by specialty. The board is actually endocrinology and metabolism. And there's not a tight link between glucagon-like peptide-1 meds, the GLP-1 meds, and lipids. There's somewhat of a loose link. We could talk about that. Anytime people lose weight, of course, their lipids get better, and the GLP-1 meds can help people do that.
I see. So let me tell people a little bit about how I found you. For the people listening to the podcast, they probably know that for about the last 13 months, I've been taking a GLP medication strictly for weight loss. I don't have diabetes. And I've lost, I think, 46 pounds at the moment. Since then, I started on Wegovy. I moved on from Wegovy to Zepbound maybe a handful of months ago now. Anyway, I think not dissimilarly to how most people end up doing things, I was about 6 or 8 months into this. And I thought, maybe I should understand better what it is I'm injecting into myself once a week. I mean, it's working fantastically. Yeah. I feel better. Everything about my life seems to be better, but I'd like to learn more about it. And I'm starting to see people with type 1 speaking openly about the successes they're having. So that led me, of course, to where any good research would lead a person to YouTube, where I found you, Tom, just doing a sit-down talking head describing GLPs to people. And I just thought you were masterful at it. And I reached out, and I'm really grateful that you reached back, because I think this is a great topic for people living with diabetes.
Yeah. Glad to be here.
Good. Thank you.
Good, nice work on the weight loss.
Oh, thank you. I appreciate it. Just about 3 weeks ago, I went to my endo, who's the one who manages my weight. She was doing my vitals, and she kept mumbling half under her breath and half in my ear, like a kid. These are great. About my BP, my blood pressure, just so much stuff that she's like, wow, it's incredible. I look like a completely different person. It's my aches and pains are gone and everything else that you would expect to come with weight loss. But then there's also been other benefits. One being that for my entirety of my adult life, without knowing it, I was running around with an incredibly low ferritin level. I was not absorbing iron, and my digestion was always poor and kind of off. And I guess just the slowing of the digestion, my last ferritin was 170. And I'm telling you, I've been in the hospital, in the ER with a 9 ferritin, where I was almost passing out. And no matter how I supplemented it, I couldn't get it to come up without iron infusions. It literally is changing my life in ways I don't even think I know yet. Anyway, I sent off a massive list of questions from listeners to you. And you've kind of boiled it down to what you want to talk about here in our first recording. And I think if you enjoy yourself, we're going to do more. So I'm going to try really hard to make you enjoy yourself. But why don't we start right at the top? GLP-1, of course, Wegovy and Ozempic, GLP-1 with a GIP, that'd be Mounjaro and Zepbound. There's others, but these are, I guess, the ones that are out in the zeitgeist right now. So let's start real basically with what is a GLP?
Yeah, a GLP-1, that stands for glucagon-like peptide 1. And the GIP that you mentioned, Scott, is, and let me just recommend everybody stick with the GIP abbreviation. It's glucose-dependent insulinotropic polypeptide. Now, okay, stick with GIP. Mm-hmm. And actually stick with GLP-1. If you say GLP, I know what you're talking about. Actually, interestingly, people make these hormones in their body, and they make them in the small intestine, and GLP-1 is made in cells called the L cells in the small intestine. And when a person eats, carb stimulates the production of GLP-1. And GIP is made in the K cells in the small intestine, and in it too is produced after carb, and maybe protein can stimulate it as well. What those normally do is the GLP-1 actually goes to the pancreas and can stimulate insulin production. So that's what they do normally. This is natural. This is what your body does all the time. So GLP-1 stimulates insulin. It also can affect another cell in the pancreas called the alpha cell. Alpha cells make another hormone called glucagon. And glucagon stimulates glucose release from the liver. And actually GLP-1 then suppresses the alpha cell. It makes then less glucagon, the alpha cell does. And there's less release of sugar from the liver. And so those are two things that GLP-1 does. Now, I'll tell you, I'm going to skip to GIP a minute. GIP stimulates insulin production from the beta cell in the pancreas. That's what it does.
Mm-hmm.
It's its main role. And we'll talk more about that in a bit, because there's some other things that GIP mimicking medicines can do. Like you mentioned, Mounjaro has GIP, and of course, Mounjaro and Zepbound are the same thing. GLP-1 does two more things, though. We talked about the insulin, the glucagon, all that. That's good. What it also does is slows gastric emptying, meaning it slows your stomach down when you eat. And it slows the emptying of the carb and everything else into the small intestine. Therefore, the carb can't get in as quickly. That lowers the amount of carb that gets in, lowers the sugar after you eat, is what it does.
Mm-hmm.
And what else happens if your stomach slows down? And Scott, you've experienced this. It makes you get full fast.
Right.
And so you don't want to eat as much. And so that's one way by which the GLP-1 type med can lower calorie intake. But also, it probably has a direct effect on the hypothalamic area that reduces appetite. And GIP can reduce appetite a bit as well. And I'm just going to go ahead and say GIP meds, that's the Mounjaro, can also, seems that they increase sensitivity to insulin, which is really interesting. And so these meds do some really good things. And it turns out that people with diabetes type 2 make plenty of this stuff. And as far as we know, people with type 1 make these too. But the effect in type 2 is reduced of these two hormones.
Mm-hmm.
And so therefore, giving people a medicine that mimics that kind of a hormone can really kind of improve things. Of course, people with type 1 don't make insulin, so you're not going to get that effect. A person with type 1 would get the lower glucagon, the gastric emptying effect, and the appetite effect. I want to just step right out in front and say, these medicines are not approved to be used in people with type 1 diabetes at this point.
Right.
They're approved for type 2.
This episode of the Juicebox Podcast is sponsored by the only CGM you can take off to get into the shower, the Eversense CGM. EversenseCGM.com/juicebox. Well, I mean, sure, you could take the other ones off, but then you'd waste a sensor and have to start over again. But not with Eversense. Eversense is a 6-month wear implantable CGM. So if you want to take a shower without anything hanging on you, pop off the transmitter, jump in the shower. When you get back out, put it back on, and you're right back to where you started. Come to think of it, you could do that whenever you wanted to. Maybe it was your prom night or your wedding day. Maybe you just don't want the thing on for a little while, but you don't want to go all through the hassle of taking it off and having to restart it and, starting back over with like wonky numbers and having to, all that goes with it when you take off a CGM and put it back on. Oh, but you don't have to do that with the Eversense CGM. Because Eversense is the only long-term CGM with 6 months of real-time glucose readings. This gives you more confidence, more convenience, and flexibility. The Eversense CGM is there for you when you want discretion, a break, or maybe just a little adult time. EversenseCGM.com/juicebox. Pop that transmitter off, pop it back on, you're right back where you started, without any wasted devices or time. A lot of people in my private Facebook group talk about their love for Omnipod 5. Have you ever seen those posts and thought, I wish I could have that experience with an insulin pump too? Well, if you've answered yes, you might be experiencing FOMO, fear of missing out on Omnipod. Symptoms may include, but are not limited to, wishing you could wear outfits without pockets, dreaming about walking past doorknobs without getting your tubing caught, or fantasizing about jumping into a swimming pool without disconnecting from your insulin pump first. Well, there's good news. You don't have to suffer from FOMO any longer. You can see what you're missing and try Omnipod 5 for yourself. Just visit omnipod.com/juicebox. That's omnipod.com/juicebox. Check it out. And is that because, I don't want to go off our path too much, but is that because at this point it hasn't been studied? And if you slow down the stomach and you eat less, then you're very possibly going to need less insulin. The people aren't going to pivot quickly enough, and then you're going to see hypoglycemia and people aren't going to know how to get out of it. Is that the fear?
The answer is to your second question is a good way to enter back into the first part of the question, your first part of the question. That is a concern with slowed emptying. and suppressed glucagon. And of course, glucagon in people with type 1, your alpha cells do make glucagon, and glucagon can help when you get low, of course. And that's what you get by injection, the glucagon injections. And your alpha cells make that, and they help regulate your sugar. So if your sugar gets low, your cells kick out glucagon. Well, if you suppress glucagon, it could increase your risk of low, number one. Number two, what you said is right. If the stomach emptying slowed down, that could increase your risk of low also. Now, back to the first part of your question, these agents have been studied in people with type 1. And I'll just briefly tell you. There were 2 studies a few years ago. We participated in one of them here. We did quite a bit of clinical research here. One thing I didn't mention when I introed, I should have, but we did quite a bit of clinical research. And we were really excited about these studies using, it was liraglutide, which you know as Victoza. And that was being studied in people with type 1. And these were large studies. And sure enough, in people with type 1 diabetes who were treated with, I'm going to say Victoza because people know this as Victoza, this liraglutide. It's one of the GLP-1 meds. It's the one you had to give every day, once a day.
Yeah.
Short duration, you have to give it once a day. And we were very excited about this. People's A1C did drop, around 0.3, 0.4, and the body weight dropped 5 kilos or so. That's good. But also, and the insulin dose reduced, no surprise. But also those people had more hypoglycemia. And also there was a little bit of an increase in ketoacidosis, diabetes-related ketoacidosis. And, that kind of caused everybody to pause. And these big studies were done, and the drug did not get approved for type 1. If you look back into those studies, I will tell you this just to let you know, the ketoacidosis episodes occurred for typical reasons. It didn't look as mysterious when I looked at the studies. And the hypoglycemia was a bit increased, but I think, it's very possible that could have been mitigated with increased change in doses and things like that. Mm-hmm. Nonetheless, though, those 2 studies kind of stopped the whole approval process for type 1 in its tracks.
Do you think it needs to be looked at again?
I do.
Yeah.
I really do. And I'll also tell you that another analysis of this whole area, kind of a pooled analysis of a number of studies with GLP-1 meds in type 1 showed certainly there was more GI side effect. We know that's going to be true in anybody that takes these medicines. There can be nausea, vomiting, diarrhea, constipation. I always tell my patients, with these meds, you could get diarrhea, constipation, nausea, vomiting, and usually it gets better. And I tell people you don't get to choose. Some of those might happen. Mm-hmm. But if this pooled analysis showed no differences in ketoacidosis, severe hypoglycemia, between the people treated with the med or the placebo. So, yeah, I think it needs to be studied more. I think anyone that listens to this should, rattle the cage of somebody and say, hey, we need to study this again and get this so it's approved.
Right.
That's my opinion. And we're very cautious about this with people with type 1. We'll talk about that more.
Yeah, no, I appreciate you being candid. I mean, listen, I think people who listen know our endocrinologist is giving my daughter a GLP. Actually, she's using Mounjaro at the moment, which seems to jive better with her. I don't know a better way of saying that.
Yeah.
The decrease in insulin use is insane.
Yeah. Yeah.
I genuinely believe my daughter will use 16,000 fewer units of insulin in the next calendar year because she's injecting 5 milligrams of Mounjaro a week.
Yeah.
It's fascinating. And her excursions, her glucose excursions are flatter. And now in fairness, she's also wearing a DIY algorithm. She's using IAPS. I don't see any more instances of hypoglycemia. As a matter of fact, without the excursions high, we're getting fewer boluses to bring her back down. I actually think it might be making less hypoglycemia than before, which isn't to say that she had a lot.
Yeah.
I've also told you a story and sent you an episode of a 15-year-old girl who's gone from 70 units a day down to now 7 units a day of total insulin, a type 1. My 7-year-old brother went from a 7 A1C with type 2 diabetes down into a 5 A1C without really even changing how he eats, and he lost 35 pounds. I mean, I know there are people who are going to have results that aren't like that, or that, you know, they have some sort of a reason why they have to stop it. But my gosh, like everything I'm seeing, just it screams for us to pay attention to this. Yeah.
I agree. I do want to emphasize that since it's not approved for people with type 1, I don't want to talk about the information for type 2 interchangeably. It would be using these medicines in a person with type 1 diabetes unless they fit certain weight criteria. And we'll talk about that more in a bit. But is off-label, meaning it's not approved.
Right.
And, you know, insurance coverage is highly variable, not guaranteed. In fact, likely it won't be covered. And so the doctors, your prescribing doctor, can use a medicine off-label if that doctor or provider feels like it's appropriate. And some will and some won't. And everybody wants to be very careful and very cautious for good reason.
Sure.
And these are some great stories, like your brother. Wow. And, you know, some people do great with these meds, and some people simply can't take them, and they can't tolerate them. And I've had a person in this morning to the office who said, you know, I tried a couple of these, and she simply could not tolerate. And we can adjust the dose sometimes and make it work, and we can use a little bit under even recommended dosing to make it work. But they're not for everybody.
Yeah.
But they really are wonderful meds for many, many people.
Right. I do wonder if in the future we won't see, it boils down to be microdosing for people with type 1 sometimes, because if you're not looking for the weight loss aspect of it or the hunger aspect of it, although, you know, when you have type 1, a lot of people with type 1 have trouble regulating their hunger and have digestion issues. It's not uncommon, right? But, you know, I want to go back before we go forward. You just said, you know, early on, one of the mechanisms of this is the fullness. You feel full. Go over again the part where your brain just doesn't tell you you're hungry, because I have both implications. So yes, I get fuller faster, right?
Right.
That's slower digestion. That's lovely. You can eat through it, by the way. You have to mindfully stop when you feel it. I can eat through it, I should say. I'm sure some people would vomit, or I've heard those stories, right?
Yeah.
But the part where your brain, like, I have to remind myself to eat. I don't get hungry very often. And if I do get hungry, it's almost always in the last 2 days of the injection, when I think the half-life is waning.
Right. Yeah. You know, there's a lot to learn here. We don't know all the answers, but there does seem to be a central effect of GLP-1 agonists. We'll call them agonists because that's what these meds are. They stimulate that GLP-1 receptor in various places. There does seem to be an appetite suppressant effect. And GIP probably does that too. So those two together work well together when it comes to the appetite part. So appetite could be partly regulated by feedback from the GI tract. That may be. And so that could be part of it. It could still be linked to the gastric emptying issue or change. But also seems to be a central effect. And what I tell people is, you know, you're taking the appetite, I call it demon. You're put into a cave and you're kind of putting a rock in front of the cave so it won't come back out, because appetite, everybody has appetite. And I'm sure over time, appetite's been a really good thing to keep people eating. And when there's food, eat. And when you're not getting enough calories, eat, you know, but appetite these days kind of throws people into high calorie intake and high carb, high anything intake. And so these meds do seem to have an effect, a central effect on appetite.
Yeah. That's fascinating. I mean, I think not like most people, I felt impacted by it immediately. And my wife's like, oh, it's a placebo. But I lost 4 pounds in the first 4 days.
Yeah.
Recently, I had to go up in my dose. Like, I was riding the 7.5 milligram dose as long as I could with the Zepbound. And my doctor, I said, hey, I put a couple of pounds on, but I'm not doing anything differently. And she said, well, I'm going to move you to 10. Actually, 10 and 12 is where I see the most weight loss. She goes, I just wanted to see how much you could get out of the 7.5. And all of the little things, like I was starting to have more sugar cravings. I was hungrier, all that stuff. I swear to you, I shot the 10. 4 or 5 hours later, I said to my wife, oh, I have that feeling of like when I started the first time in my stomach. My body regulated to it. I've been using it for 13 months. So, in a day I felt better. And now it's been 4 days since I did that. And I've already lost 4 pounds.
Yeah.
And I have not, I swear to everybody listening, I haven't changed my activity. I haven't changed my hydration. I haven't eaten any differently. I'm losing weight now. It's absolutely fantastic. And to watch it work on my daughter's blood sugar is magical. I couldn't get her. She's away at college. And so as I was switching her to Mounjaro, because she was using Ozempic, in fairness, we were getting this through a Canadian pharmacy, so everybody understands how it's happening. I had to ship it to her, and it was late to getting to her. And in 5 days past her injection day, her blood sugars got completely wonky. We had to make all kinds of adjustments to her basal, to her insulin to carb ratio, to her insulin sensitivity factor, just to get her through the 4 days. And then she injected it. And I talked to her last night, and I said, listen to me right now, put all of your settings back. And we are going to be looking for lows over the next 36 hours, just in case. Now, the algorithm's getting ahead of it. But as soon as the medication hit her, her blood sugars all like flattened out and stabilized again. It's crazy.
That's really interesting. And you said a few things that are really important, Scott. One is it's not approved, so it's not going to get covered. You're getting it from Canada, which of course, I as a prescribing doc, I can't write scripts and send them to Canada. They have to be, I can write a script that you could take anywhere you want. And that's one thing. And the other thing is you definitely want to be cautious because you're right, hypoglycemia is possible. And then you treat it with oral carb and it may not get absorbed quickly. So, the stomach slowed down. So you've got to be really cautious about that. And if a person's had diabetes for a long time, they might have gastroparesis, and that is slowed down emptying because of some nerve involvement from the diabetes. And then they definitely would get double the slowing. And that would be a person who wouldn't want to take it. So we have to be the stories are great. And the results can be really interesting when you're using it an off-label again. I'll say that repeatedly because I want everybody to know that is the story right now with type 1. But you just have to be very careful about it and select people properly and be careful about and understand the drug itself may make it a little difficult to treat hypos and could create hypos.
Mm-hmm. Yeah, and it's going to be such a case-by-case situation. Not that everything about diabetes isn't.
Right.
But at the same time, like when this becomes more accepted or covered by insurance or everything, it's going to take some real overseeing by people who understand what's going on because your transition's so important. If somebody wouldn't have told me in the very beginning, hey, it feels like your food stops halfway down your chest for the first couple of weeks, which is how I would describe Wegovy when I first started taking it, I might have panicked. If somebody wouldn't have said to me, like, do not eat crazy, I don't anyway, but do not eat crazy fatty or greasy foods, you might throw up. I had help moving into it. I had good direction, and it's why I was able to navigate it because the truth is there's a lot there to navigate. People ask, like, what are your implications? And I had diarrhea in the beginning, but I said to myself, I know that when my body regulates to this, I have a good chance of this stopping. So I'm going to try to make it through because I want the other side of this. Because, Tom, I thought I was going to have a heart attack. I was carrying all my weight in my stomach. I'm classically ready to have a heart attack,
Yeah, yeah.
So anyway, we're going to go back and forth here, but let's talk about the half-life and the dosing, right? So I'm sure everybody doesn't know what half-life means, but you can explain it to them and tell them why it's important with this.
Yeah. Thank you for asking. Half-life is, you can look at it two different ways. One is the time it takes when you give a medicine for it, when you stop it, the time it takes to reach half the level of the dosing. Another way to look at it is the time that it takes to reach the steady state as you give a medicine. So if the half-life is a day, that means it takes about a day for the drug, when you give a dose, to reach 50%, be metabolized, excreted, whatever. And so it tells you a lot about the duration of the medicine in the body. And then when you're creating dosing frequency, it tells you how often you have to give the dose. So, I mean, if I gave a medicine that had a half-life of a day, would I want to wait 2 days to give the next dose? No, because you want to give it every day to maintain the level of the med. And we could go on and on about various meds, but the relevance here is that some of these medicines have very long half-lives, meaning they can be dosed infrequently. And some of them have shorter half-lives. They have to be dosed more often. And for example, Ozempic, Wegovy, semaglutide, and that Rybelsus is the pill version of that. That drug has a half-life of a week. So it can be given once a week because it stays around for a long time. The medicine like the Mounjaro, and that's also Zepbound, okay?
Mm-hmm.
As you pointed out earlier, that one has a half-life of 5 days, so it can be given once a week too. And we could go on and on about that. Victoza has a half-life of about 13 hours. So you really have to give that every day to maintain that level. So the beauty of these new meds that we're talking about, the Ozempic, Wegovy, Zepbound, Mounjaro, those meds can be given once a week, which is very convenient, really, in relative to other meds.
Yeah.
And so that makes a difference.
Oh, it's fantastic. And I think Novo's working on a pill, a once daily pill. God, it'll probably be 10 years before you see it. But I think that I mean researchers, pharma companies, they obviously see what's going on at this point. Like, it's the amount of people who use this don't have side effects that don't stop them and are having insane kinds of, transformations, both health and visually.
Yeah.
It's going to be a focus. But, it brings me to this point that you put on your list here. Like, what is overweight and obesity? And I really do want to hear from you, because what you're seeing right now in the zeitgeist, right, the way people talk about this is you'll either find somebody who says, wow, whatever works for you, that's fantastic, good for you, which is how I think about it. Or you'll hear somebody say, well, work harder, eat better. And sometimes to those people, I say, okay, fair enough. There are plenty of people who are not getting movement and are not eating well, and they're overweight. But I can tell you that from my perspective, I was not eating poorly.
Right.
My entire life, this has been my situation. I used to joke with people, if I ate like you did, I'd gain 5 pounds. I retained water like a pregnant lady, I would tell people, right? Like, if you and I went out to dinner and had a normal meal, I'd be 3 pounds, 5 pounds heavier the next day. I couldn't tell you why. I didn't eat differently than you did. And so can we talk about this a little bit? Like, just weight and obesity, how you think about it in relation to these medications?
Yes. There's a lot of data that shows that as people gain weight, certain things happen. And if there wasn't some risk to gaining weight, we wouldn't care. You may not like the way it looks, but it has medical consequences. And that's where a lot of the treatment sort of motivations come from. And it turns out that as people gain weight over their usual ideal weight, then you start seeing things like high blood pressure, high cholesterol, type 2 diabetes, insulin resistance. And, it's well known that people with type 2 diabetes have insulin resistance. Some of that's genetic, some of it's acquired, like when people gain weight. And so, it's kind of arbitrary when you set a cut point to say over a certain amount of weight over ideal is a problem, because sometimes people can gain 5 or 10 pounds and things go to pot when it comes to metabolic things like I talked about. But a commonly accepted standard for overweight that can cause medical issues is a BMI of 27. Now, BMI, what is BMI? Everybody, I think, when you go to get a checkup, you get your weight, your height, and those two can be put together into a formula, and it's body mass index. BMI is body mass index. It's an index that takes into account height and weight. So a person who's 6'10", weighs 210, that's probably okay. Mm-hmm. A person who's 5'2", that has a weight of 210, that's way over. So it takes into account height and weight, BMI. We could go on and on about that, but I'll just tell you, the currently accepted standard is at 27 plus on the BMI. Over 27 is overweight. And that person is high risk for things like all those things I talked about: high blood pressure, high cholesterol, type 2 diabetes, insulin resistance. And over a BMI of 30 is called obese. And there are other cuts that are higher than that too, but those are the two classics. Again, BMI is calculated by height and weight. If you wonder what yours is, you could go to a table online. When you go see your medical person, you can say, what's my BMI? Because the EMR is calculated pretty much automatically these days. That's in adults. And I do want to talk a little bit about pediatrics, a little different. There are various standards for defining obesity in pediatrics. The most accepted one here in this country is obesity in pediatrics is a weight that's over the 95th percentile. So you get out of BMI, you could use BMI a little bit, but you get out of BMI and you end up looking at percentiles. That is comparing people to other people their age.
Yeah.
There's so much dynamic changes that occur in the pediatric population as they get older. Height changes, weight changes, all that. So obesity in pediatrics is defined as a weight that's over the 95th percentile of other comparable people that like age matched, and that goes from the ages of 2 to 19.
Mm-hmm. Is there an increase over decades in young people being overweight?
Absolutely.
Is that, in your opinion, is it a little bit of everything? Is it movement? Is it what's in our food? Is it how we eat? Is it how often we eat? It's an amalgam of these things?
Yes.
Yeah.
I mean, I could expound on that, but you nailed it.
Okay.
It's the diet. It's nature, for sure. Genetics determine things, determine metabolic rate, and you can see overweight in families. But it's also nurture. It's the environment we live in,
mm-hmm.
and activity changes over time. And what everybody knows what's going on. A lot of times people are glued to the computer or to the phone or something like that, sitting still a lot. In the old days, that didn't happen. And we could talk on and on, but you're exactly right about that, Scott.
Okay. So as a clinician, how do you think about it? Meaning, maybe I should back up and ask this question. How many times in your career have you told somebody to lose weight and they've actually done it?
I'll answer that as many, many times.
Mm-hmm.
I think people understand the concepts of calories in, calories out. And, I'll say exercise is always important. You mentioned exercise earlier in your own particular experience, and 20% of weight loss is related to exercise, unless somebody's an elite athlete or a very athletic and exercises all the time. Most people don't. So exercise is important, and reducing calories is important. But I'll tell you, I think people respond and are successful many times. The problem is the long-term part of it. People are successful frequently for a while, and on average, they tend to gain it back. We're all busy. We're exposed to calories all the time. Activity is challenging sometimes because of scheduling or just understanding about the amount that you need. So I think people really can lose weight on their own. And some people can lose weight on their own and keep it off and do really well and understand the medical part of it. But for the most part, it's really challenging. A lot of it has to do with the environment that we live in.
My take on that is, in a world where I can't impact the environment, right? I can't just, it's nice to say, like, I love turning on a podcast or TV show. You hear a rich person say, get out and move around. I'm like, well, you have $9 million in the bank. That's great. You know what I mean? Like, I've got to get up and sit back down and make this podcast all day, or I don't get to pay my electric bill. And that's how this works, right?
Right.
When that's the environment, do you have any moral qualms with giving people medication just to lose weight?
The answer is no. That's the answer. But, when I have a medicine that I think is safe and effective and I understand, then I'm much more comfortable prescribing. We've gone through all kinds of medicines over time, and some of them we still have. I mean, GLP-1s are not the only medicines approved for weight loss.
Right.
And some of them I feel comfortable with. Others, I don't like the side effects, and I don't like the idea of long-term. I've increasingly come to think and know, and I think most people in this area are similar, that any medicine we use is going to need to be long-term.
Right.
And for example, I mean, let's just go look at other, like type 1 diabetes. It's not like you can take the insulin for a while and then get off of it. And various medicines, thyroid hormone. It's not like you can take thyroid hormone for a month or two and then get off and everything's okay. It's a continuing need for treatment, and people call it chronic condition. So I think the weight loss medicine is going to have to be that way too, because as you pointed out, you get toward the end of the cycle of these very effective meds, and the appetite comes back. It tries to come out from, the appetite demon tries to come back.
Yeah,
and you just have to keep it where it is. And so I think chronic treatment is the way to go with this type med.
Yeah, I've heard people describe a food noise in their head that goes away. Mm-hmm. My wife got hypothyroidism, And it took us 7 years to talk a doctor into giving her medication for it. And in that time, she gained a significant amount of weight, which she's almost completely all lost on Wegovy now. And she describes, and I'm going to have her on at some point to tell it in her words, but she describes that she would open her eyes in the morning and be thinking about food before she was even conscious. And then as she was making breakfast, she'd start wondering what she was going to have for lunch. And she said, it's all gone. It just doesn't happen anymore, which makes it much, much easier. And then then it impacts the insulin and that your body's using, keeping in mind she doesn't have diabetes, right? And then the weight starts coming off, and then the metabolic stuff gets better. And that's in there. I think for me personally, the most significant part is the way I end up describing it is my body works better with the GLP. I don't really care what that means. And I, by the way, am now more active than I was before because A, I lost weight, B, I have more energy, my joints don't hurt. Like I am more active now than I was prior. It was easier to get going. It was easier to pick up weights and go, hey, I'm going to lift these now. It's a nice say, go ahead and lift some weights and go for a walk, etc. Except every time I tried to do something, I ended up getting a knee surgery or something like that. Because in fairness, my body was too big. And every time I tried to use it, I'm older and it would break. And so if we can all basically agree that there's stuff in the food we shouldn't be eating, and maybe stuff we're spraying on the food that we shouldn't be eating, and we're microwaving in plastic, and there's 90,000 different kinds of oils, three of them apparently could be, or one of them could apparently be an industrial lubricant, the way it's created out, right? And we're eating this stuff all the time. And over time, people don't even understand what good food and bad food is anymore in many situations. To say to people, I threw you in this cesspool, and I could pull you out, but you should climb out. I don't understand that. Like, I really don't. Like, what is it you're saying to people if you're fighting against this idea? Now, is this ideal? It's not. But until GLPs make food come out of the ground tasting like candy and being good for you like lettuce, I don't know what else we're going to do, because this is where we are now. That's my opinion of it.
Yeah.
It's nice to hear other people wanting to be helpful for those who are stuck in that. Also, there are plenty of thin people who are not healthy either. So, they're eating the same crappy food too. Their bodies just aren't reacting the same way as mine did, if that makes sense.
Yeah, I think that makes sense. Yeah, your body, it was built for a certain amount of weight. Your chassis, your skeleton was built for a certain amount of weight. Your internal metabolics work better with a certain amount of weight. And when we load the body with more, things happen to the metabolics, and they also, as you pointed out, they happen to the structural part too. The knees, cancers are higher in frequency. I don't have a study that tells you when you lose weight, your cancer risk goes down. I would think that's probably true, but nonetheless, we know that overweight is correlated to all kinds of things, cardiovascular, cancer, all of that. And then losing weight is actually really important. For some people, losing 40 pounds is what's needed. Some people lose 10 and they do a lot better.
Yeah. Tom, listen, I didn't even go to college. I have no background in medical whatsoever. I'm better off now than I was last year.
Yeah.
That my common sense tells me.
Right.
I've joked with people, if I grow a horn out of the middle of my head and it literally says Manjaro up it, I'll go, at least I'm not going to die of a heart attack. You'd have to show me some really tough health concerns about using this for me to think about I'd be better off 40 pounds heavier.
Yeah, yeah.
So here's the thing that we don't talk about enough, and maybe you could. These medications, they started being researched in the 80s. Is that story about the Gila monster and the Canadian researcher, is that true?
That's pretty true.
Yeah.
Yeah. The research started many, many years ago, and there was something in the Gila monster spit that was kind of similar. And one of the early medicines that you probably remember was Byetta, which is exenatide. We don't really use it much anymore. It had a very short half-life. It had to be given twice a day. It was effective. It caused lots of side effects. It had peaks and valleys because it had to be given so often. And yeah, these are not brand new. You nailed it. I mean, Ozempic has been out since 2017.
Yeah.
Byetta was approved long before that. And then we had a long-acting Byetta kind of thing, like exenatide, that was Bydureon, you probably remember. And one or two came and went because they just didn't have enough uniqueness to actually be used very much. And then along came Victoza, and we used that quite a bit. That eventually got approved as the drug Saxenda. They're the same thing for weight loss. And then, people started observing, oh, these are good for diabetes, but they also, they cause weight loss. And most of the drugs before that we used for diabetes, including insulin, would be associated with weight gain. And we'd say, oh, that's good weight gain because your sugars are better. But nobody that I know of who listened to that smiled.
Yeah, right.
And there's no weight gain's good.
Yeah.
Yeah, they've been around for a while.
Yeah, it's tough because you lose weight when you're diagnosed with type 1 very frequently because you're, drifting away from life and you don't realize it at first. And then you reintroduce the insulin and then you get back to the caloric intake that is normal for you, which for some people is more calories than they needed. And then they start gaining weight and then they say, oh, the insulin's making me gain weight. And I always try to tell people, like, generally speaking, it's the calories you're taking in that help you gain weight. Now, the insulin's putting it, is storing it for you. And do you agree with that generally, or is there more to it than that?
I agree with that.
Okay.
Everybody, everyone's different, and not everyone, but I mean, in general, it's still safe to say it's a good concept. Everyone has a different metabolic rate, and they deal with calories differently. Frankly, calorie burn is genetic. Appetite is partly genetic. Attitudes about food are acquired, but we grow up in our families and certain attitudes about food, amount of food. People are told eat 3 round meals a day and, have a dessert.
Yeah.
We live life in real time and we eat. And so the calories, it would be kind of interesting if everybody had a custom calorie for their particular body. And that can be calculated, but still the environment we live in, it's so easy to get calories. A handful of nuts, there's lots of calories. Go look that up. I use the net, and as many people do in Siri, I just say, hey, Siri, how many calories in a handful of walnuts or something? And it's like, wow. And I still remember when I was in training, we were asked to have a dietitian sit down with us, and I would go over to the hospital every day and grab lunch. Lunch was, an event, and we got time off to do it. And I was having a chili dog with French fries and a regular drink. And the dietitian calculated calories for that. And I thought, it's going to be like 450, but it was like 1,000. And I'll tell you, that kind of feedback was a reality check. And I never had a chili dog again, I'll tell you, because it just floored me. So if you look at what you actually eat, everyone, you've done this, you do this, then you'll find some interesting things.
I'll tell you that I had an experience last week where I started eating something I hadn't eaten in a while, and I enjoyed it and I ate it. And then I injected the 10 milligrams up from the 7.5, and I reached for it on the counter one day, and I actually thought to myself, oh, I don't want this.
Right.
Like the idea of it nauseated me.
Yeah.
And I was like, but 5 days prior, without 2.5 more milligrams of this medication, I was like, oh, this is good. I like this. It really is fascinating.
Changes your attitudes. And something, there's nothing wrong with that. That's good. I mean, people do. You asked the question earlier, is that really okay? And the answer is, if it works and it's safe and you tolerate it, go for it. Yeah. That's what you should be doing.
Is overweight and obesity an issue in the type 1 community more so than in the regular community?
I've had people tell me, oh, overweight's not a problem in the type 1, it's type 2. And I look at them and go, no, that's not true. I know that because of the people I see in my office. People with type 1 diabetes have the same struggles with appetite, and maybe sometimes more so, as the people with type 2 and struggles with weight. If you look at stats, I mean, I could say, is it 20, 50, or 80% of people with type 1 who are overweight or obese, based on that definition I gave you earlier? And most people would probably say 20%. I think most of the people in the medical world right now would say 50 or more. It's not 80, but if 50% of people with type 1 are overweight or obese, and I'll just say this, type 2 diabetes, people with type 2 have not cornered the market on overweight or obesity, and they haven't cornered the market on insulin resistance. People with type 1 can have genetics that are insulin resistant, and when you gain weight, you get more insulin resistant, whether you have type 1 or type 2.
Yeah.
So it's a common issue. It's talked about more and more. And yes, we really do need some good studies with, I hope, this kind of medicine, looking at people with type 1. And I'm going to tell you more about it. I can tell you now, and there's a study that's going on. But we need more studies that look at this in people with type 1. And we need to find ways to mitigate risk. And we can do it.
When you say we need studies, where does that have to come from? Is it a pharma company that has to say, hey, I want to sell to these people, so I have to prove it works? Is it researchers? Like, who are we looking for to jump in and carry this load for us?
Yeah. It's the pharma companies. And there were these studies early on that there was a lot of optimism, and we all assumed it was all going to be approved, and it wasn't. They have to go through the FDA. They have to show all the adverse events associated with medicines, and everybody has to come to an agreement. It just didn't happen. So the pharma company typically would have to put together a sizable enough study, which is very expensive, and then show effect, and then show manageable side effects to get it through the FDA. Currently, there are some studies going on. In fact, I'll just jump in a minute and tell you about one. There's been reluctance to proceed. Of course, most people with diabetes have type 2, and then there's just people who are overweight who don't have diabetes at all. And then there are people with overweight who have prediabetes. And that's where the numbers are, and that's where they're going for. A big part of me says, when you want something and you have type 1 diabetes, go to the JDRF and say, hey, please lobby for this, because they have an organization and they know how to do that, and they're really good at that.
Yeah.
If I went to a company and I said, I want to put 50 people with type 1 on this medicine, and I probably could get funding to do the study. That's not nearly enough people, though, to get it by the FDA. So it really has to be a large study. Question is, what about these weekly meds? That's those two studies I told you about that had the ketoacidosis and the hypoglycemia were in the once-a-day drug, the liraglutide, the Victoza. What about the weekly meds? We don't know. We need studies. Now, there is a study going on right now, and I'll just jump in and say something about it. It's called CARMOD, CARMOT. That's just the name of the study. And a company is studying a medicine such as we're talking about specifically in people with type 1 diabetes who are either overweight or obese. So this is a phase 2 study, meaning it's going to turn into, hopefully, if things look good, into a bigger study, phase 3. Now, that's the kind of study that needs to be done, and that is ongoing. That's not from Novo or Lilly. It's a different company.
Mm-hmm.
And we are involved in that study here. And in fact, if anyone is in the Austin, Texas region that wants to be with type 1 diabetes, who could be categorized as overweight or obese, we're looking for people for that study. So these studies, please, I would encourage everyone to volunteer for some of these studies, as you have in the past. Every medicine that's approved for type 1, type 2, anything, has people who volunteered to a study. Jump on in there and help those things get approved, or at least get them studied. They may not get approved. You never know.
Yeah. Tom, I'll get some information from you afterwards. I could probably funnel some people towards you that would help with that.
Perfect.
And also, let's take a moment to chide Lilly and Novo, who both in their charters say that they're around to help people with type 1 diabetes. So here's your opportunity. Spend a little money and help them. The big problem here is there's not enough people to sell it to afterwards. That's the bigger problem. Yeah. There's not enough type 1s for them to think of it as a splash. But my gosh, like, you're looking at really impacting people's lives, because, listen, I think you can hear through the raindrops when Tom's talking. If he was in charge, if you were the Wizard of Oz, you'd give this to people, right? You'd do the study, come up with the protocol, and give it to people with type 1. Is that fair to say?
And the answer is yes, I would. And I would be very, very careful. I would talk about all the things we talked about with the little part of my head saying, there was a study that showed increased ketoacidosis, but then another larger kind of analysis said probably not. It doesn't make a lot of sense to me that it would cause that. I can come up with mechanisms. When you look at the studies, you come up with your own impressions.
Yeah.
And it looks like those people might have developed it anyway. And then hypoglycemia, that one I get. That one I really do understand, and I know how to mitigate. And what you said earlier, your lupin, your daughter's lupin, and even the automated insulin delivery devices from all of the manufacturers, since hypoglycemia or since the progression towards it, and they back off the insulin. So with those devices that lots of people with type 1 are using, would there be an issue at all with hypo? The answer is I don't know. It needs to be studied.
We live in a world where, generally speaking, people with type 1 diabetes don't know how to accurately adjust their insulin to begin with. And often they see doctors who are not much more help. So then to say that I'll inject something in you that's going to lower your insulin needs, who's going to adjust the insulin? Like, the user doesn't know how to do it. The doctor doesn't know how to do it. That's where the rubber's going to hit the road right there. You're going to have to tell people, look, we're going to inject. When Arden gave herself the first injection of Ozempic, we spent the next 3 days changing her settings. It was that significant and that quick. And then after we got them right, it was fine. And that was it. So, anyway.
Yeah.
I'm sorry. Can I say, and about the DKA thing?
Yes.
I bet you could have gathered all those people up and just checked them for DKA and came up with similar numbers without the GLP. But that's my guess based on nothing other than talking to people for years about diabetes.
Well, I will say in those studies, there was a group on placebo and a group on treatment, and the people on placebo, that is the comparison in a scientific study where you actually have people who aren't on and who are on, and the people who weren't on didn't have the ketoacidosis. I can't say that.
Interesting.
And why did it cluster in that particular group on treatment? And it tended to be the higher dose. So maybe the nausea from the higher dose sort of covered nausea from something else going on, like ketoacidosis, so people were kind of misled. It's possible that the lower insulin dose needed made people more prone to have ketosis because they had less insulin going in. I don't know.
And they were still eating regularly because they weren't being slowed down from eating. I wonder, there's a lot in there.
Yeah. There's,
like you said, I think further study might prove out that that's not something to be overly concerned about.
Well, it's something to be very careful, definitely. And what you said is very important about adjusting for the first 3 days. These studies that are the one that we're talking about, the Carmot study that we're doing, we have a very clear kind of direction as to how to adjust insulin right off the bat to be very cautious. And so we don't know if a person's going to go on the real thing or not. And we adjust the insulin in a certain way. And so these studies should look not only, and they are, this one study, looking at not only the effect and the side effects, but it's also looking at a treatment kind of algorithm approach to reducing the insulin.
Yeah. Do you have any patients of yours, type 1, who you've given them a script and they're paying cash?
And I'll say I do.
Yeah.
And, I'm writing it off. It's off label. And what I tell people is, I tell them about all the side effects. I say it's not approved by the FDA. And if you look at the approvals, many times it says specifically not approved for type 1. And I tell them that and give them a prescription if I think is appropriate. We start low. We always start low, and then we increase the dose as appropriate. It is off label, and I'm going to say that so many times. And I tell them it could bring out some major GI problems, and you may really not like it. You may not be able to take it. You may have to discontinue it. And we're really cautious. Yeah. But I do have people who are overweight with type 1. And I will point out, and we can talk more about this later, that actually there are instances in which it could be covered in people with type 1. And that would be the overweight obesity indication. And that would be the main one, actually.
Yeah.
So if someone, and then also with Wegovy, there's an indication for using if a person's overweight or obese, and if they have a cardiovascular disease. So if someone has a history of, say, a heart attack or stents or bypass or whatever, and if they're overweight, then there's a really, really interesting study that showed a reduction in major cardiovascular events in people given Wegovy. It wasn't in people with type 1, but there were a few people with type 1 in the studies, it turns out, and they still fit that indication. I hope that made sense.
It does. Do you think we'll see an approval one day or a study one day for PCOS? Have you seen the people talking about that? The mass amount of women in these Facebook groups who are getting pregnant before they're losing weight on GLPs?
Yeah. Yeah. People with PCO, weight loss can improve fertility in people with PCO and without. And there are studies that are done, small studies, there are ongoing studies. Are we going to see an approval? I don't know. Yeah. I don't see a big study being done in people with PCO at this point. I may not be aware of one that's being done, possible, but I think it's really an interesting thought.
I think a lot of women suffer with it quietly.
They do.
Yeah, and it's not looked at.
And it's highly connected to overweight. You said it right. It's highly connected to overweight and insulin resistance. And if you lose weight, the insulin sensitivity improves, ovulation improves. Really interesting.
I'm going to share a story that I can't tell you who the person is, but I know them very well. And mid-20s, female, not, growing up heavy, then not heavy, mostly not as an adult through college. And then suddenly in the last year, just gained 60 pounds. They're working out crazy, eating as clean as they can, gaining weight through the whole thing. Doctor says you have PCOS. We told her, go back to the doctor, see if they'll give you a Wegovy, something like that. Wegovy or Zepbound. Doctor gave her Wegovy. She shot it on Saturday morning over FaceTime with me because she couldn't bring herself to do it. I had to talk her through it. And she got it in and sent me a text 36 hours later that said, I've lost 5 pounds. I don't know what that means or how to measure that, but that's insane. Like, that's not water weight. Do you know what I mean? Like it is probably some of it, but she's stopped eating in the past for 36 hours and nothing's happened. And she's eating super clean to begin with, and she's active and everything else. Like, I don't think we have the answer yet, but you can't tell me that there's not something happening here that's not commiserate to the idea of thyroid stimulating hormone, right? Like my body's making it, but it's not using it correctly. Like there's got to be something there making those GLP receptors light up that's changing people on a metabolic level. Like, and maybe I'll be wrong one day, but in the moment, this is how I'm thinking about it.
Yeah.
Yeah.
Well, I mean, I'll say 36 hours, 5 pounds. There's a lot of water there, I think. I mean, or something, or maybe there was a big blowout diarrhea. I don't know. But, usually on any diet, when a person lowers calories, typically the first week or two, you lose a lot of water weight for various reasons. Part of it's decreased salt intake, and part of it is kind of the ketone formation thing and the less calorie in and all that too.
I agree with you totally, but she was already doing that.
Yeah.
There was never a moment whether her ass just exploded and she just had diarrhea, or whatever it was, that still didn't happen to her when she was eating clean, exercising, and et cetera, and so on.
Yeah.
Who knows? Like, I have no idea. I can tell you my daughter's acne is almost completely gone, and she was not overweight to begin with.
Yeah. We have well, I will say we have lots to learn. And I will emphasize to the audience, these are anecdotal.
Oh, please. Yeah, of course.
Examples of effect, not that everyone's going to get anything like that. And some people are really not going to tolerate it. And I have some people who simply can't take it. It's too bad.
Can we talk about that?
Some people don't have, some people don't have as much weight loss as we're talking about either. So life is a bell-shaped curve, and response to a medicine is too. Yeah. And we tend to talk about the real yet exceptional examples, but remember, not everyone gets that result.
Talk to me about the not tolerating it. When you don't tolerate it, what does it look like?
The main thing is GI, and it's typically just what we talked about, that gastric emptying change, and maybe even some central effect can induce nausea, vomiting. It tends to get better over time. We always start with the low dose, and we titrate or increase the dose very gradually. If we increase the dose and then a person gets side effects, we back off, and that's very doable. You have to work with your healthcare person when it comes to that. And so diarrhea and constipation, the medicines typically slow down the GI tract all the way down, but some people can get diarrhea as well. Commonly, those effects are tolerable or get better. I had a gentleman in this morning who told me he's taking one of the meds, and that at the highest dose, he gets really tight in his abdomen and very uncomfortable. And he's backed it off. And I encouraged him to continue to, and try to find a happy medium, because the GI tract is in the balance here. Some people can't take it. And if you look at studies, 4 up to 8% of people on these meds discontinue because of the GI side effects. Now, those effects can be managed with medicine. I don't like to treat the side effect of one medicine with another, but sometimes temporary use of like anti-nauseals can help. And you could use medicines that are antidiarrheals too. Same concept, but that typically are temporary, but not always. And so people need to be aware that it just happens. It's not your fault if that happens. I will say this: if you have nausea, and maybe anyway, remember that high fat slows the stomach down too.
Mm-hmm.
So if you add fat plus a GLP-1, your chance of nausea goes right up. So one thing to do is cut the fat back a bit.
Yeah. No, I don't eat high fat to begin with. I don't use any oils almost at all in my life, but I was very careful about that. I also, if I don't see myself going to the bathroom, I add a little magnesium oxide to my supplementing.
Yeah.
I knew how important it was to keep the process rolling once I started this. Like if I don't see myself going every day on this, I hydrate, I take the magnesium, like I keep things moving. I know there are some, people love to yell in the media about stuff like this, but have people been injured permanently from it at all that you know of? Like, I mean, and is that got something to do with who they were before they started? Or could it, because I think the fear is like randomly, you're just not going to be able to, like, I don't know, digest food anymore. Like, you know what I mean? Like people get, when they hear about it and you hear them panic about it, they say kind of bombastic things like that. Is there a call for concern?
Something, when we talked about half-life earlier, I mentioned that the weak half-life means that it takes a week to reach 50%. I'll tell the audience, it typically takes 5 half-lives for a medicine to get totally out of your body.
Mm-hmm.
So if a medicine has a long half-life, it's going to take a while for it to get out. So if you have a symptom that you don't like and you're going to stop the medicine, it's not like you stop it and it just goes away with this type of medicine because of the long half-life. The symptoms of like the slowed gastric emptying are going to go on for a while, and maybe they'll go on longer than that. But there's really no clear evidence that those go on forever. And some people have underlying gastroparesis, and we don't know.
Mm-hmm.
And we might bring it out, make it worse. And then after they get off the med, they may get diagnosed, and they may think, well, I have this now, because the answer is I think they probably had it before. And there's still a lot to learn, but there's no clear evidence out of studies that there's a permanent impairment.
Right. Okay.
And there are other side effects too we could talk about, but that's, I think, the main one that people talk about.
I would never minimize anybody's experience, but
me either. Yeah.
But I want to say this, and I want to lead with that. I've interviewed thousands of people, and I have access to my Facebook group that has 50,000 active people in it. And so when my daughter at 18 years old was told by a GI doctor she had gastroparesis, even though her A1C had been in the 5s and the low 6s for most of her life, I didn't accept that. And we went and looked at other ideas and added a digestive enzyme to her process of eating, which made all of her stomach pain go away. I shared that on the podcast, and I have to tell you that the amount of people with type 1 who I hear back from who just said to me, I thought my stomach was going to hurt the rest of my life. I thought there was something wrong with me. My body was broken, et cetera, and so on. Now I've added this, and it's all gone. It just cleared up. So we don't talk enough about when you get type 1 diabetes, some people get digestive problems, right? I mean, they used to give amylin out like it was like candy to type 1s, but now suddenly we don't do that anymore. So we ignore the possible digestive implications of having type 1 diabetes. And then when people talk about stomach issues, they send them right to a GI doc who just jumps right to, you have slow gastric emptying, you have gastroparesis.
Yeah.
And I wonder if it wouldn't be helpful if people were better educated about that and spoke more about that to their patients. Do you find yourself seeing those things?
Yeah, I think it's a really good point. And I think gastroparesis should be diagnosed based on, commonly some testing to document what's going on. And I think if anyone goes to their GI doc, please, if you're on a GLP-1, tell them about that. Because everyone, we in the endocrine world, diabetes world, we're all up on it, but not everyone is. And I can't tell you how many people now, the GI docs I work with are really sharp, and they picked up on this very quickly. But I got some calls early on from people saying, hey, I just did an endoscopy on somebody who's on that medicine, and there's still fluid in their stomach, and they haven't eaten anything since last night. We've learned a lot. We've learned that can happen. Mm-hmm. Slowed gastric emptying can leave contents there for a while, and you need to be aware of that if you're a GI doctor. And then this thing about symptoms too. I've had people go through major GI workups and they're told finally, well, everything's okay. Take these medicines that it might help. And then they come back to my office and I go, oh, you're on this medicine that probably caused all those symptoms. And did y'all talk about that? And the answer is there's been a lot learned and things have gotten a lot clearer. But these medicines, if you slow the stomach down, what happens? Well, you slow the stomach down, you could get fuller. And like my patient said earlier, it felt like his stomach was tight.
Yeah.
And that's no surprise. You can also have that gastric juice be kind of pushed up the esophagus because there's more pressure and you could get some esophagitis. So it's important to kind of understand the implications of that gastric emptying thing.
Well, I have to tell you, my acid reflux has completely gone away on a GLP.
Great.
Yeah.
Good.
Is that common?
All things are possible there. They could get worse. I mean, you said it's got better for you.
Yeah.
And so the various things can happen.
Okay.
Most people really don't have an increase in reflux. Some do. And I can understand how it could get better too. Mm-hmm. So there you go. And a lot of variability from person to person.
I think we're coming up on our time. Is that right?
We could go a little bit longer.
A little longer. Can I ask you about, two things. So first of all, availability. Are you seeing it get better? I know there was a flood somewhere that slowed it down for a little bit. Like, do you think that they just can't keep up with this? Do you think that so many people are using it? Why are we seeing this? Do you think it'll clear up at some point?
Yeah, availability has been a big deal. And I think part of it is related to some manufacturing difficulties. Part of it, the most of it, I think, is due just to pure demand. I mean, these medicines are in high demand. And we almost need a pipeline. There's so much that is needed and needs to be distributed. And we've seen the Ozempic supply became very challenging. And it's improved a little bit in my experience. Wegovy, challenging and maybe getting better. I keep hearing next month it's going to be better. And then the next month comes and it's not better.
June.
It's in the next month. Yeah. And then now Mounjaro has had some tight supply, Zepbound as well. And of course, we as treatment people, I want my people with diabetes to have availability to the medicines they need.
Right.
And I like people losing weight. That's great. Mm-hmm. And so, people that don't have diabetes who need to lose weight, that's important. People with diabetes, big deal. So, there's this kind of back and forth about, people who really need it aren't getting it. Really need it. What's the definition of that? But that would be, I think most people think there's people with diabetes. Again, we're talking type 2 because remember, these are not approved in general for type 1.
I mean, listen, they want to make money, right? They've got to figure out a way to get on top of it. I think one of them, Lilly just bought a new place down south somewhere, or they bought somebody else's building and they're manufacturing there, trying to get set up for it. I don't think it's because they're not trying. To me, it lends to the idea of doing studies in other populations, because if it's this popular now and you're not going to be able to stop taking it, and we have no shortage of people who could use it for diabetes and or weight or hunger or PCOS or whatever we end up using it for, like moving forward, find more people to give it to so you can make excuses to build more buildings and hire more people and produce more. I've heard of people getting it through China, through a Canadian pharmacy, and that was happening like that for a while. It's insane.
Yeah, your point's well taken.
Yeah.
I think the demand surprised everyone. The potential, the benefit has been embraced, and there's a shortage, which I think will cure in the next few months. Of course, I said that 3 or 4 months ago too.
Do you think that the demand was surprising is an indication that it works?
I do.
Yeah,
I do. And I think that people understand that people with diabetes that have under the indication benefit a great deal from it. And that's really a big deal because lowering the A1C reduces risk of complications of diabetes and helps all the metabolic issues that occur with diabetes. And we know now that at least a few of these are approved for reducing cardiovascular risk. Mm-hmm. The studies were done in people with known heart disease, of course, but we know that too. There are benefits all the way around. But I think the people who don't have the diabetes and those risks still want it because weight loss is something people want. And for good reason. Yeah. I can't blame them at all.
Can I give you my big theory?
Yes.
I think that after a generation of people using GLP medications and basically learning to eat less and eat better because they're being chemically kind of directed like that, that we might raise a new generation of people who don't eat poorly. I know that's a big idea. It's a generational idea, but how do your kids end up eating poorly? It's because you eat poorly and you maybe don't even know it. I use this example all the time. My mom, who's passed now, was told she was pre-diabetic a few years ago. And she called me and said, Scott, they say I have pre-diabetes. I'm gonna change up my diet completely. I said, that's great, Mom. And then I visited her a week later and I opened up her refrigerator and everything she bought couldn't have been a worse decision. Like, she just didn't know the right things to eat.
Right.
And that's the lady who taught me how to eat.
Right.
And then I taught my kids how to eat, except I got lucky at some point and said to myself, we're doing this wrong. My wife and I were like, we both grew up very blue collar, very simply. Nobody understood, nutrition at all. And what we considered to be good food was just the stuff we couldn't afford that we got once in a while as a treat. And that made it good food. It's really interesting, like how we think about what's actually good for us. So that's my big idea. My big idea is if we take a generation of parents and right their thinking, that they might raise a generation of kids who don't get into. I can see in 3 generations this completely flipping the other way and forcing Agra to move with it, because if we're not buying it, they're not going to make it. That's kind of how I feel about it.
I like your idea.
Yeah.
I think starting early with pretty much anything when it comes to kids is going to have long-term consequences. And I think dietary, approaches at early ages that are good make things happen.
Mm.
I've actually know some very young children who eat nothing but vegetables and all that all day, it seems. And they do like ice cream and that, but they don't, it's a treat. It's not a common, it's not something they expect, but they don't like some of the things that are really what we'd consider to be high fat, and they're just because their taste buds are they're acclimated to things that are different and they're healthy. And I do think you start early, whether it comes to food or various things like stay away from drugs and cigarettes and all that. I think you start early and you teach the kids how to go. It
just becomes kind of second nature.
Yeah,
I do a pro tip series about diabetes with a CDE, or excuse me, with a woman who's got type 1 diabetes and is a nutritionist, and her children eat fantastically, but so does she.
Yeah.
And that, I think it just is what it is. Also, I have to tell you, Tom, if you're willing to do this a few more times, I think you and I are going to have a pro tip series on GLPs together, because this is fantastic. I can't thank you enough for spending the time. And we didn't even get to the listener questions yet. So
no, there's a lot to talk about. No, I'd love to.
Okay.
I would love to.
That's great. Kate, listen, do you accept new patients at the practice, or would it not benefit you for us to share your information like that?
I really don't see new patients. I do supervise a lot of people, advanced practice providers. We have an excellent group here who are really experts on diabetes, but we're a single specialty. We have 12 doctors and 3 offices here. So though I don't see new patients, we as a practice, we see new patients all the time.
Okay.
In the Austin area, people come from various, and we do diabetes, all endocrine. So, some listing that would include the practice predominantly. And
I will for great. Sure. Tell me the website.
Yeah, it's texasdiabetes.com.
Okay.
Yeah,
I'll put it in the show notes as well. And I'm not kidding you. When you get done, you send me the study information that I can share online. I'll put it in a place where a lot of people will see it for you.
Okay, I'll do it. I will do that. Thank you. Yeah, I appreciate that.
Oh, it's my pleasure.
Scott, let's put off the Afrezza a little bit, because first of all, we'll probably want to do more GLP-1 first, because there are quite a few things we didn't get to. You're right, and we need to, like the muscle mass change, all that stuff, preparing for surgery, all that, very practical. But the Afrezza thing, American Diabetes is late June, and there's going to be a study presented that will make that discussion more useful.
Okay.
And I can't talk about the results before then. So anyway, if that's okay.
Can I leave this part in, you talking about it like that?
Yes.
Okay, because what I see here I'm going to keep recording. You're back with me in 2 weeks. I think we need that one and one more to get through GLP.
Okay, that's fine.
And then do a fourth one on Afrezza. I think that would be terrific.
That'd be great. Okay, cool. Very good. All right.
Use that link I gave you and grab a couple more recording dates.
I'll do it. Okay.
All right, Tom, this has been fantastic. No, you're amazing. Thank you. Take care.
Okay. All right. Bye.
A huge thank you to Eversense CGM for sponsoring this episode of the podcast. Are you tired of having to change your sensor every 7 to 14 days? With the Eversense CGM, you just replace it once every 6 months via a simple in-office visit. Learn more and get started today at eversensecgm.com/juicebox. Don't forget to get rid of that FUMU. Go to omnipod.com/juicebox. That's omnipod.com/juicebox. Check out the Omnipod 5. Get rid of that FUMU today. If you're looking for community, check out the private Facebook group, Juicebox Podcast, Type 1 Diabetes. But everyone is welcome. Type 2, gestational, as long as you're impacted by diabetes, you're welcome in my private group. It's absolutely free and currently has 50,000 members. We add 150 new members every 3 days. The Diabetes Variables series from the Juicebox Podcast goes over all the little things that affect your diabetes that you might not think about. From travel and exercise to hydration and even trampolines. Juiceboxpodcast.com. Go up in the menu and click on Diabetes Variables. If you or a loved one was just diagnosed with type 1 diabetes and you're looking for some fresh perspective, the Bold Beginnings series from the Juicebox Podcast is a terrific place to start. That series is with myself and Jenny Smith. Jenny is a CDCES, a registered dietitian, and a type 1 for over 35 years. And in the Bold Beginnings series, Jenny and I are going to answer the questions that most people have after a type 1 diabetes diagnosis. The series begins at episode 698 in your podcast player, or you can go to juiceboxpodcast.com and click on Bold Beginnings in the menu. If you're not already subscribed or following in your favorite audio app, please take the time now to do that. It really helps the show. And get those automatic downloads set up so you never miss an episode. Thank you so much for listening. I'll be back very soon with another episode of the Juicebox Podcast. The episode you just heard was professionally edited by Wrong Way Recording. WrongWayRecording.com.